about multinodular goiter, what is needed for the evaluation and management of patients that present with that. And to start off, multinodular goiter, or MNG, is defined as any thyroid with a nodule that's with more than one nodule is very common, greater than 1 centimeter. The prevalence of palpable thyroid nodules is slightly greater than 6% in women and 1.5% in men. This increases as age increases, increased in iodine deficient areas, more common in individuals with a history of radiation exposure. Oftentimes they're benign in 95% of cases and malignant in 5% of cases. Papillary cancer constitutes the majority, which is 75 to 80% of malignant thyroid nodules, followed by follicular cancer, which is 15 to 20%. Now remember, the papillary cancer constitutes the majority of these thyroid nodules. That's 75 to 80% of highlight malignant thyroid nodules, followed by follicular cancer, which is 15 to 20%, followed by medullary cancer, anaplastic cancer, and thyroid lymphoma. And these are under the umbrella of palpable thyroid nodules. The prevalence of non-palpable thyroid nodules, I think that's really, they did a study, they did an autopsy studies that showed the prevalence is in greater than 50%. Approximately 1/3 of the non-palpable thyroid nodules had a 2 centimeter thyroid that was missed during their lifetime, and that was found on autopsies. The ultrasound shows that the prevalence varies with age of patient, rate in middle-aged women greater than 50%, and routine ultrasound, really important, is not recommended for screening unless patient has a family history of thyroid cancer or history of radiation exposure to head or neck. Ultrasound shows additional unsuspected nodules in 50% of patients with single palpable nodules. So basically what that means is once you can find a palpable nodule on ultrasound, most likely there's more than one. Okay, but the autopsy that was done, studies that were done, showed a lot of them were missing nodules on patients that they didn't necessarily die from having these nodules. But a lot of us, basically the take-home is that we missed them a lot, and they were palpable, and they were big at 2 centimeters, which should be palpable. So we want to get really good at being able to determine if patient has nodules. So that's the premise of that study. The prevalence of multinodular goiter is increased, so the prevalence of multinodular goiter increases in iodine deficiency areas. Female patients, older patients, and patients who smoke cigarettes also have an increased prevalence. If they smoke, if they're female, and they're older patients, and also if they have an increase in if there's an increase in iodine deficient areas. Iodine sufficient areas, there was a study in the Framingham data showed that 1% of patients from the age of 30 to 59 years had a palpable multinodular goiter. There was a similar study in Connecticut which showed the prevalence of 2% of palpable multinodular goiter. Iodine deficient areas in Denmark, there was a prevalence of 10% in mildly iodine deficient areas and 15% in moderately iodine deficient areas. Prevalence increases by 50% when the goiter is defined by ultrasound. So the etiology of the prevalence of multinodular goiter is most likely due to partial genetic defects in enzymes. Okay, so it's most likely due to partial genetic defects in enzymes, which are involved in the production of thyroid hormone. And this is combined with environmental factors such as iodine deficiency or other goiter. They're called goiter-oncogenes, meaning they cause goiter. And these are goiter-oncogenes are drugs, any drugs that can cause a goiter. Cigarette smoke is also considered a goiter-oncogene, and that's spelled Goitrogens, all of which compromises the ability of the thyroid to produce hormone efficiently. If you have chronic stimulation of thyrotropin, which is TSH, this induces heterogeneous hyperplasia, the overgrowth of cells in the thyroid. So if you have chronic stimulation of thyrotropin, which is TSH, this introduces a heterogeneous hyperplasia in the thyroid. This results in the rise in cell turnover. It also increases the likelihood of sporadic mutagenesis, meaning a lot. And this mutagenesis is believed to result in the localized growth of certain clones of cells that develop into these autonomous nodules. Basically, the summary of this is the combination of environmental, genetic, endogenous factors leads to the formation of a simple nodule goiter. Endemic goiter develops in iron deficiency areas. So endemic meaning those iron deficient areas can cause a goiter. And that is iodine deficient areas. I said iron, it's iodine, okay? Please, I apologize for that. It's iodine deficient areas. We already did iron. Environmental goiter oncogenes, the effect of foods is not clinically relevant unless they compromise the majority of the diet. So certain foods like cassava, okay, interferes with thyroid peroxidase, okay, and that enzyme organophilize iodine and incorporates it into the thyroglobulin to produce thyroid hormone. It affects the release of the thyroid hormone or uptake of iodine into the gland. So it makes that thyroid work over and over again. When we talk about endemic goiter, there are certain areas in Africa where that's all that they eat is cassava. And we know that cassava affects the thyroid. It does something to that hormone, and basically it affects the release of the thyroid hormone or the uptake of iodine into the gland. So the enzyme what cassava does, it interferes with thyroid peroxidase. And this enzyme that organophilize the iodine and incorporates it into the thyroglobulin to produce thyroid hormone. And it affects the release of the thyroid hormone or uptake of iodine into the gland. Other causes are selenium deficiency, and to some extent, severe iron deficiency impairs the synthesis of thyroid hormone. The natural history of multinodular goiter, it usually involves gradual increase in size, the development of multiple nodules over time, and the development of autonomous thyroid nodule. Basically what that means, it produces a hormone independent of the TSH control. but not to the point of overt hyperthyroidism or an increased thyroid function. Autonomous thyroid nodules is indicated by mildly decreased or low normal level of TSH. The establishment of treatment plan can be challenging because the rate of growth is difficult to predict in any given individual. Like, for example, long-term growth is poorly studied, but the average annual rate of growth is usually from the multinodular goiters is 4.5% to 5%. Reflux of postnasal drip may mimic early symptoms of mildly enlarged thyroid, and that clinicians must distinguish between, like they use this, and I said this in class, the signal and the noise in making the diagnosis. Meaning, what is real? Is this postnasal drip, or is this a sign of multinodular goiter? TSH suppression, even mild degree, causes harm. TSH and the nearly undetectable levels are associated with adverse consequences. And those are to bone in postmenopausal women. Also, these patients are risk for atrial fibrillation, increased threefold in individuals with undetectable TSH. And the risk for total mortality also slightly is increased. And these studies were assessed. Studies have been assessed at the rate at which autonomy and hyperfunction develop. So the Dutch study looked at 140 patients with multinodular goiter. 90 patients were followed up in 5 years, and 22% transitioned from normal to abnormally low, but not completely suppressed. The TSH in 12% of these patients transitioned from autonomous thyroid nodule to mildly overtly hyperthyroid in patients with modest, locally asymptomatic multinodular goiter. We have to monitor the TSH over time because of the tendency of the multinodular goiter to grow. That is the take home. So initially, the point is, it might show a low TSH. Okay, you might find it, the multinodular goiter. The patient has low TSH, okay, but it's still detectable. When it becomes undetectable, that's really, really serious, okay? So you're going to watch, it's a watch and wait game, and you'll be working with the endocrinologist and the type of people. But to know that this is undetectable thyroid is like 0.5, almost 0. You know, that's undetectable TSH, and that's serious. So the workup is you obtain an adequate history, you examine the thyroid gland, you measure TSH, you characterize the number, size, and other features of the nodules. And that's the results from the ultrasound. If TSH is suppressed or undetectable, perform a thyroid scan and a 24-hour radioactive iodine uptake. Know that malignancy is very rare and present in only 1% of these cases. If TSH is suppressed and nodular hyperfunctioning and sufficiently large to be of concern, biopsy usually not recommended for hyperfunctioning nodules unless there's unusual features presented. Routine thyroid scan is not recommended if TSH is normal or near normal. Very important point. Routine measurement of serum thyroglobulin is not recommended. Any thyroid abnormality can cause an elevation of serum thyroglobulin. Routine measurement of serum calcitonin is not cost effective and indicated only if the patient has single or multiple thyroid nodules. Family history of multiple endocrine neoplasma, cancer cells, type 2 or medullary thyroid carcinoma, or atypical results on fine needle aspiration of suspicious thyroid nodules. Those are the patients we worry about. And when you get the ultrasound back, indications for evaluation is hypoechoic nodule greater than 1 centimeter in size, Heterogeneous, not hypoechoic, but solid, nodules 1.5 centimeter in size, and nodules greater than 2 centimeters in size in patients with mostly cystic nodules. So I know that's a lot of information. The differential diagnosis, the clinical issues, determine whether multinodular goiter causes local compressive symptoms, whether the nodule is autonomous or hypofunctioning. And that can usually be determined by the TSH. Is it near normal? If it is near normal, you're going to watch. And whether thyroid cancer is present, or risk for cancer in multinodular goiter is similar to that in solitary nodule. Although the risk for cancer in any given nodule although the risk for some, like less than 5%, is about 5% for patients with any there's a 5% risk of cancer in anyone that has multinodular goiter. Dominant or concerning nodules on ultrasound may warrant fine needle aspiration. However, there was a study found that fine needle aspiration of largest, this is really important, largest nodule, irrespective of characteristics of other various nodules that were found in ultrasound. This may cause 30 to 50% of cancers to be missed in patients with greater than 2 nodules. Look at the size, but also the characteristics of nodules. Fine needle aspiration reveals benign nodules in 75% of cases, and nodules suspicious for or consistent with malignancy in less than 5% of cases. Findings are indeterminate in 15 to 20% of cases. So that means an indeterminate finding, they can't say it's not cancer. So these are the gray zones. Very cute. There are 2 categories of indeterminate results. Include consistent with follicular neoplasm, likelihood of cancer 20%, and atypia cells of unclear significance. There's also a likelihood of cancer 5 to 15%. If the fine needle aspiration is unable to distinguish follicular adenoma from follicular carcinoma, in the past, patients with indeterminate results on fine needle aspiration were referred to surgeons for definitive surgical histological diagnosis. Presently, patients are referred for a repeat biopsy with measurement of molecular markers. This is an accepted clinical practice in many areas, but not yet standard of care. If repeat fine needle aspiration continues to show follicular neoplasm or atypia cells, we want to test for messenger RNA expression and look for a benign pattern, which is a negative predictive value of 94 to 95%. So that's one of the new things that they're doing, is to do a repeat fine needle aspiration and test for messenger RNA expression. And they're looking for a benign pattern, which is negative predictive value of 94 to 95%, if present. Evaluation of compressive symptoms. Give patients who experience bothersome choking or pressure sensation in neck option of surgery. Medication not effective for symptomatic and large multinodular goiter. Ask the patients about shortness of breath. Look for evidence of stridor, hoarseness, not explained by gastroesophageal reflux or postnasal drip. If the size of the nodule is in question, patient, for example, has more symptoms than expected, look for possible posterior enlargement, and you might have to perform a non-contrast CT of the neck and upper chest to visualize like any substernal extension, posterior growth, and tracheal deviation or compression. The administration of contrast, intravenous IV, iodine contrast in patients with underlying autonomous thyroid nodule temporarily increases the production of thyroid hormone. This is called the Jod-Basedow effect. In patients with unusual respiratory symptoms, you want to perform pulmonary function tests with flow volume loop to rule out underlying reactive airway disease. A barium swallow is recommended if patient has difficulty swallowing. Extrathoracic obstruction of trachea results in cutoff on inspiratory limb of flow volume loop. Basically, this is what the endocrinologist is going to be doing, but sometimes you can have specialists that aren't working them up, and you are concerned, and you're the primary care provider, so you got to know a little bit about what's expected of the endocrinologist, so you feel like your patient is getting treated with the proper care. The treatment of symptomatic multinodular goiter is levothyroxine, LT4, suppressive therapy, ineffective, and does not change long-term natural history of multinodular goiter. May result in slightly temporary decrease in growth rate or size if TSH is normal, but effect loss as soon as therapy discontinued. It's indicated if TSH is frankly elevated. The optimal therapy, total or near total thyroidectomy performed by experienced surgeon, bilateral surgery indicated if disease present on both sides, if single nodule large and causes symptoms on one side, surgical removal indicated even if the nodule is benign. If you have contralateral side completely normal, a hemothyroidectomy may be adequate. Radioactive iodine can be used for non-toxic multinodular goiter, but more effective in patients with hypothyroidism, high dose 100 to 20 of the radioactive iodine, and that's required to achieve a treatment effect, particularly in large goiter. It's safe, does not cause sudden increase in size of thyroid or further compression of trachea. Improvement of symptoms are seen in 75% of cases, with some cross-sectional area trachea increasing by approximately 1/3. Rate of radiation thyroiditis or pain in area thyroid. Symptoms respond well to non-steroidal anti-inflammatory drugs, so we want to give them steroids. Transient hyperthyroidism due to leak of performed hormone from gland may occur occasionally, and we want to treat with beta blockers. Hypothyroidism occurs variably, and it's present in less than 50% of cases. Treatment of toxic multinodular goiter tends to result in preferential uptake of radioactive iodine into most highly autonomous nodule areas. And these where our areas between the nodules tend to be relatively suppressed with less uptake of thyroid hormone. And remember that when you have a person that's diagnosed with hyperthyroidism and they can't sleep at night because it's so uncomfortable, these patients are uncomfortable, you want to at least start them on Indeterminate, okay? That's really, really important because they're uncomfortable, at least until they see the endocrinologist. In summary, about 25% of cases are autonomous on presentation. They develop an additional 10% to 20% of cases anticipated over the next 7 years. Eventually, 1/4 to 1/3 of cases develop suppression of TSH sufficient to require treatment of iodine 131 ablation with iodine. Ablation, is indicated if patient hyperthyroid or has markedly autonomous nodules and other medical problems that require treatment, but no suspicious nodule requiring surgical evaluation. It's also indicated if local symptoms present and patient not a surgical candidate. Surgery is indicated if fine needle aspiration findings raise concern for cancer or if the patient has significant local compressive symptoms. Anti-thyroid drugs play a small role in toxic multinodular goiter. Patients who decline iodine ablation can be treated with methomazole, methimazole. So anti-thyroid drugs play a small role in toxic multinodular goiter. Patients who decline iodine or ablation can be treated with methimazole. Treatment with methimazole does not lead to remission. It's indicated in patients for whom iodine or ablation is not feasible. Anti-thyroid drugs can be used to prevent Jod-Basedow effect, Jod, Basedow. It's in your textbook, so you might want to look that over. So that's when IV contrast is given to patient and increases the production of thyroid hormone. So in patients with iodine ablation not feasible, anti-thyroid drugs can be used to prevent the Jod-Basedow effect in patients with low TSH for whom iodine load is planned. So they're going to give iodine. They don't want the TSH to increase. Therefore, they will give them anti-thyroid drugs. Methimazole is an anti-thyroid drug. So this was a lot. If you have any specific questions and you don't understand, for those of you who weren't in class, I'm happy to answer any questions. Please let me know. Thank you.